So good afternoon, everyone. I'm Jody Dart. I'm the statewide coordinator for ACMI. Thank you all for joining us here today. I'm going to introduce our Deborah Humphrey, who's the executive director of the Madison County Mental Health Board. She is the chair of our Children's Behavioral Health Committee, and she'll be doing an introduction today and moderating the session. So with that, thank you for joining us. And Deborah, if you'd like to get started.
Thank you, Jody, and thank you, Dr. Dana Weiner and Regina Crider, for being with us today to share with us the Blueprint for Transformation, a plan to improve Illinois children's behavioral health. And the vision, I think it started out with just looking at what is the vision we want to see in Illinois for children's behavioral health. And our Children's Behavioral Health Committee has actually reviewed the blueprint and tried to see where there was some alignment. So I'm hoping today will bring some more thought-provoking information that, again, we can look at. Again, we're representatives at the local level. And Regina and you and I met a few months ago to kind of talk about some things regarding families and family support type things that you're doing as well. So again, thank you both for being here. I'm going to do introductions. Dr. Dana Weiner is a Chapin Hall Senior Policy Fellow with over 20 years of experience providing technical assistance, program evaluation, and data analytics support to child serving systems across the country. She is currently serving in the office of Illinois Governor J.B. Pritzker as the Chief Officer for Children's Behavioral Health Transformation. In this role, she oversees the implementation of recommendations to adjust capacity and to streamline access to mental health services for youth. Dr. Weiner holds a bachelor's degree from Cornell University and a PhD in clinical psychology from Northwestern University. And Regina Crider. Regina Crider is a senior policy analyst for community and parent leadership at Chapin Hall. She comes to this role based on her lived experience, specifically work on the implementation to transform the Illinois children's behavioral health care system and described in the Blueprint for Transformation. Crider is deeply familiar with the impact of human service policies on families, both from her own experience as a consumer of human services and from the experience of working with children and families in need of intensive behavioral health services. She's a statewide trainer and national speaker for children's mental health. For 15 years, she has worked as an advocate for youth and families across various child serving systems in Illinois. She is also founder of the Youth and Family Alliance and has served as the executive director for 8 years. She believes that families can solve their problems when given the appropriate supports. In 2022, she was appointed to the Illinois Children's Mental Health Partnership by Governor J.B. Pritzker as the intern board chair, and she also chairs the NB subcommittee for HFS Medicaid Advisory Committee. Currently, she serves as the vice president for a family-run executive directors leadership association and is a director of the Illinois Children's Healthcare Foundation board, where she chairs the Equity, Diversity, Inclusion Committee. Most recently, she has joined the Illinois Collaboration for Youth and Eastern Illinois Food Bank Board of Directors. Welcome, both of you, and thank you for your presentation today.
Thank you for having us. Man, Regina, you're busy. Okay, so I'm going to kick us off, I think, and then Regina will talk a little bit about the part of this work that she is leading. And let's see if I can get these moved. Okay, so what we're going to do is give you an overview of the progress on implementing the blueprint. And I think you mentioned you've reviewed and are familiar with the blueprint. We issued a progress report that was released on January 29th. And if you don't have it, when I'm done speaking, I can put it in the chat. And so then Regina's going to talk a little bit about the work we're doing to build up community networks. And then we'll kind of tell you how you can be involved with us and invite your collaboration either in thinking about these issues with us on this call or going forward if you would like to keep in touch with us and weigh in on some of the other things we're doing. So the Children's Behavioral Health Initiative was launched in February of 2022 by Governor Pritzker in recognition of the fact that we were coming out of the pandemic, we were in the midst of a youth mental health crisis. Youth mental health problems were on the rise before the pandemic, but the pandemic exacerbated them with isolation and stress and and workforce shortage. So the goals of the initiative were that young people with significant behavioral health needs get the community and residential services that they need to thrive, and that caregivers have transparency and clarity about how to get services for their kids, which is something that was sorely missing, as we'll talk about in a second. So this work didn't start with me. Probably back in 2015, there was a recognition that kids were coming into DCFS care unnecessarily because they needed psychiatric services. And Sarah Feigenholtz spearheaded the effort to pass the Custody Relinquishment Prevention Act. I came on the scene in 2022 with the announcement of the initiative and had about 10 months to develop the blueprint, which you saw as a result of many, many conversations with people, data analyzed, best practices examined from other parts of the country. And then we worked with the General Assembly to develop legislation to make it possible to implement the activities described in the blueprint, because the governor in February of 2023 issued an executive order that Illinois would adopt this plan, which is kind of unprecedented and wonderful that we have support from the legislative and executive branches of Illinois government. So being asked to improve our Illinois children's behavioral health service system was challenging, because we don't really have a system so much as we have a patchwork of programs and services that are delivered by 6 different state agencies. You've got DCFS, which is the Child Welfare Agency, DHS, which houses divisions of mental health and developmental disabilities, the Department of Juvenile Justice, which has programs and services for kids in aftercare, the Department of Public Health, which oversees inpatient hospitalization, the Illinois State Board of Ed, that has 852 local school districts that all deliver services to kids who have individualized education plans, and the State Medicaid Agency, HFS. So it's not that our state doesn't have anything for mental health. We have a lot of things, but they're not all organized under one umbrella. And in some states, they're more organized under one umbrella. So it is uniquely challenging in Illinois to coordinate across these different entities. So I talked to a lot of people in developing the blueprint, and I've talked to many, many more people since. I think I'm up to over 4,500 people. I have to check. My project coordinator, Louisa, keeps track. But in talking to all those people, I heard a number of explanations for the problems in our state. First explanation that everybody mentions is we don't have enough. We don't have enough of the services that we need. So it's a capacity explanation. The second is it's too hard to access the services that we do have. The third is the policies and laws are not aligned with the outcomes that we want to see or with our ability to effectively serve families. The fourth explanation was we don't do a good enough job engaging families. We make a phone call, maybe we send an email, but we don't actually connect with families effectively, gain their trust, and keep that connection long enough to serve kids. And then the last explanation was practice, that we don't have enough high quality evidence-based interventions so that we treat problems effectively the first time we see kids. So this is what the people said. But when I talked to parents, what they said, particularly as it relates to seeking residential services for those kids with really complex needs, what I heard is that getting to those services is like wading through a dark, unmarked forest. It's confusing, it's scary, it's frustrating, and you're not even sure what your destination is, because it's like residential services and people don't even really know what that is or what it's for. Now, there are 5 ways that the state can help a child get residential services. 2 of them we don't like to rely on, DCFS and the Department of Juvenile Justice. Those are not the best ways, because those bring kids into a system that then it's hard to get them out of. But the other 3 ways, through the state Illinois school districts that are overseen by the State Board of Ed, the Department of Human Services has the developmental disabilities waiver for kids who have developmental disabilities. And then the Medicaid agency has the family support program. You might remember once upon a time that program was called Individualized Care Grants, ICGs. Now it's the family support program. So we're trying to make it look more like this, so that no matter what door you come in, you're met with a helpful person. You can see I have a little park ranger there, and trail maps, clear guidance for what you can get and what it's for, and a clearly differentiated array of service types, particularly in this residential space. But my concern is not just residential. In fact, when the initiative was launched, you might remember in February of 2022, it was in the news, there were 55 DCFS wards who were in hospitals for psychiatric reasons beyond medical necessity. And the DCFS director was being held in contempt of court for failure to get timely placements for those kids. But those 55 kids were the tippy tip of a much bigger iceberg of kids who need help in our state, many of whom don't get it in time. So in order for families to experience our system like this, we actually have to rebuild it from the inside so it looks like this. And that's what I've been working on doing. So I'm going to talk a little bit about the ways in which we're doing that, building a centralized portal for all the information to come into one place, and then working across the agencies to make sure that we can access all the services that kids need that are available to them. So if you read the blueprint, you saw there are 12 strategies outlined in it. And 4 of them are focused on streamlining and centralizing access to services. 4 more are designed to adjust capacity to get at those capacity shortfalls, either by making more kids eligible for things, making it easier for providers to partner, or adjusting the rates so that we actually can use all of the beds that we have when the need is residential. And then 4 more strategies are aimed at allowing us to intervene earlier and get upstream to prevent the kinds of problems that land kids in the hospital. Some of the kids we see who are stuck in the hospital, if their needs had been attended to 2 years ago, 3 years ago, when someone first knew there was a problem, they might not have ever decompensated to the point where they need such intensive interventions. So we're going to talk about these 3 strategies a little bit more specifically because we think they're the most relevant for the work that you're doing. But if we can talk about anything on here, this is all I do. It's my whole job. I'm happy to talk about any part of it. But I thought I would zoom in on talking about the centralized care portal that will be coming online in July, the increases in capacity, and then Regina will talk about what we're doing to strengthen community networks. You've all seen the blueprint, so you don't need to scan this QR code, but I can put the link in the chat in case you haven't seen it. What you probably also are aware of is that in August, on August 11th, the governor signed Public Act 103-0546 into law. And that had 8 provisions in it to make this work possible. So there were some statutory changes that were needed to let us start to do things in a different way. And actually, there's 5 more statutory changes that I just testified for in a new bill in the Senate Bill 3316. I have to start memorizing that number too, which has 5 more provisions. But these provisions established a position for the officer, that's me, created the team, the interagency team that's working together, mandated that we build the portal, it helped us to expand the CCBYS program, modified the role of the CRSA program, which you might or might not know about, but happy to talk about it, required the Illinois State Board of Ed to build the foundation for screenings, for school screenings, which are not yet required, but we're working toward a system where they will be universally offered, required for the district, not required for the student. And then some other things that have to do with some back-end data and fiscal levers that are pretty important to changing our system. So happy to talk about any of that. So the state did not have the option to implement just 1 or 2 of those 12 strategies. To solve the problem, we need to do all of those things. We can't fix it with just 1 or 2 things. So this was a graphic that I usually use to explain how do we get at our 5 goals: capacity, accessibility, earlier intervention, agility, and accountability with these 12 strategies. But we also are keeping track of how that implementation is going. And if you didn't see the progress report released on the 29th of January, I will put it I'll put it in the chat either way. But this is how we keep track of our progress. So each of the 12 strategies is listed here, and the length of the dark blue bar is how long it's going to take us to get to implementation. Now, we're working on all of these simultaneously. We did not start with one. There's no sequence. We're doing it all at the same time. But it's like 12 trains left the station and they're not all getting to their destination at the same time. And how close they are to their destination is the gray bar inside the blue bar. That's like how far along we are. And where we are today is that dotted line. So this is what we use to keep track of our own progress. And I should mention that we spread the love across the state agencies. So we are partnering with them on doing these things, but it's not one agency that's responsible for everything, even though each of them feels like they're doing the biggest part of the work. They're all really doing a lot of work. And you can see here, like the dark green, the bright green square is the agency that's primarily responsible for that recommendation. But in addition to the agencies, because we're not just relying on them to do it, we have a team of Chapin Hall leaders. Regina is one of them. She is leading the work in that bottom quadrant on recommendation 11 and recommendation 12, which we're going to talk to you about today. But we have other leaders. Regina has a counterpart leading the programs work, the tech work, the school work, and then I lead the data and fiscal work. So in our first year of implementation, we accomplished a lot. And these are just some of the highlights. One is that we negotiated a deal with Google to build the care portal. So in the picture where we're rebuilding parents' experience so that there's a centralized place to go, Google is building that, and it will be called Beacon. And Beacon will, at least an initial version of Beacon, will be ready in July. And not only is Google building it, but they chipped in $1.5 million to bridge a funding gap because I think they want to build it like all over the country. And so they really want to make it great so that everybody sees it and wants one. But that works for us because I also want it to be great. We also have an interagency team that meets on Friday mornings to expedite placement and staffing for the kids who are stuck. Like they're stuck in the hospital, or they're stuck in the ER, or in their parents' home, or somewhere where they shouldn't be because they're waiting on an intensive treatment. If you know about kids who are stuck and you don't know what to do about them, let me know and I will tell you how to get in touch with that team. But we have successfully resolved over, today we're at 75% of those cases. Over 220 of those cases we've resolved by working together in ways that the state agencies haven't historically worked together. Also, ISB completed the landscape scan that was required in the legislation, and we learned some really interesting things. 2/3 of school districts are already doing mental health screening. About 28% of them are doing universal mental health screening. So to all the people who said, you're never going to get the schools to do it. Well, 2/3 of them, 28% are already doing universal screening. Another 43% have some form of screening underway. So that was great news. The other piece of great news, which Regina is going to talk to you about, is that we thought, when I wrote the blueprint, I thought, oh, we need to find a way to reinvigorate the LANs, the local area networks. We got to get back our community networks. But it turned out when we looked into it, when Regina inventoried the networks across the state, every county except for one has a thriving network. They're not all LANs. Some are SOC grants or 708 boards. Regina will tell you about it, but they all have networks, which is really good. And then the last thing is we launched a provider capacity reporting tool, because one of the problems we found with the very long waits for some kinds of services is that the state doesn't have a full picture of what beds are available, what slots are available. So we're changing that as well. And now we have a tool to do it. So for every recommendation in the blueprint, we have a very detailed sequence. This is an oversimplification for recommendation 1. We have a very detailed sequence of steps that we're going through, that we're following. For the building the care portal, those steps involved developing a business process map, vetting it with people with lived experience, figuring out how is this going to look like, designing it, then planning and hiring for the jobs that are needed and working with a vendor to figure out what the tool is going to look like. And then in July, when Google's ready with our new Beacon portal, we'll be able to install it and see how it goes and hear feedback from people. And later in this presentation, I will give you the QR code if you want to stay in touch with us to hear about new developments in this work. But for now, I'm going to zoom in on recommendation 1, and then I'll talk about number 7 for just a minute, and then I'll hand it over to Regina to talk about number 12. So, okay, recommendation 1 is to build this centralized portal. And one of the first things I did in the spring of 2022 was to recognize that if these agencies are going to work together to expedite placement and services, they need a tool to do it and a more streamlined process. Because when you ask state agencies to work together, they almost always say, legally, we can't share information. technologically, our systems don't speak to each other. So I built a little portal with DHS IT that automated their process. And here's what it looks like. This is what you see when you get it. And then you have to answer these 8 questions. This exists now. We use it every day. And you could enter a youth in it, and you would need to know, are they Medicaid eligible? Do they have an IEP, developmental disability, et cetera, et cetera. And then this portal, based on those questions, it picks a quarterback. It says, you catch the ball, you get consent from the family gives consent, and then we're all allowed to talk to each other about the case. And because this is a secure and private state-owned system, they can all talk to each other freely in ways that they couldn't before. So this portal that we stood up early on, I say it's rudimentary, it's like not very fancy. It does 3 things. 1, it created this centralized place for the agencies to practice working together. Because it's only by having them, because of that patchwork I showed you in the beginning, it's only by having them work together that we can solve these problems. 2, it overcame the legal and technological barriers to the agencies talking to each other about cases. And 3, very importantly for me, it created a data source to understand what the barriers are and who's having the hardest time getting the services they need. This also, and I should put this on this slide, it served as a test case to convince the state to dedicate $4 million to building a portal, because now they can see it works. They can see that we've staffed 300 cases using it. They can see that it speeds up the amount of time before kids get services. So that's how we make the case then for Google to build the new portal. So the new portal is going to be called Beacon. It is, I should tell you what it's not. It is not a diagnostic tool. It will not decide what services a kid needs. It is not an AI response that gives you a bot to talk to. What Beacon is a routing application. It's a single place for families to go to get information about what their kids are eligible for, so they don't have to do 20 searches online. And it gives that families a place to upload documents so they don't have to tell their story 17 times. They can put the IP up there. They can put whatever applications they've filled out up there. And then all the state agencies can see them, and they don't need to keep bothering the family to fill out more stuff. We basically tried to look at the barriers we had uncovered and address them with this piece of technology. It lets the agencies talk to each other, and it, lastly and importantly, it offers the families a navigator. It says, would you like help? And then we're building this cohort of navigators and from different places. Some are from NAMI Chicago. Some are from the Caroline Warren line. Some are from IDMH that's hosting this, the Division of Mental Health. Some are from the Community Residential Services Authority, but there will be navigational help for families who need an assistant. So we are working with Google on this. They move really, really fast. It's terrifying how fast they move, but fortunately they're very good at what they do, and they're listening closely to everything we say. So they're delivering this tool in what they call sprints, and every few weeks they show us something. And in a few minutes, when we get to the end, I'll let you know how, if you want to be a user testing for Beacon, it's a commitment. You got to do your homework. You have to watch a demo, then you get an assignment of cases, and you have to basically, you're trying to see if you can find any bugs in it. But if you like stuff like that, let me know, and we can have you help us. What Beacon is going to do, though, and this is just kind of a crude overview of how cases flow through Beacon. You'll see a page that will say, what do you need, information or services? If all you need is information, you'll get sent to the Spider resource directory for now, until we have a statewide tool that we're also procuring. If you need services, we'll ask you what kind of services, because if it's a crisis, you go to 988 or CARES. And if you need residential services, you go to the interagency team. But if you need community-based services, you'll have the opportunity to enter some information, and then you will be offered some options. So that's the Beacon overview. The other thing I wanted to say, and then it will be Regina's turn, is that as part of recommendation 7, we are building capacity. It's slow going. We can't solve this problem overnight, and we have a workforce shortage, which we're trying to address separately in recommendation 11. But for building capacity, we have built some. So I'll just quickly tell you about it. In the blueprint, you've seen that I divided this into things we have that are too hard to get, things we don't have enough of, and things we don't have at all. So in the things we have that are too hard to get, top of my list was the PUNS list. You may or may not know what the PUNS list is. If there's a child with a developmental disability, historically, they have to get on that list, and then they wait and wait and wait. And I don't know that kids were ever getting pulled off that list. Last year, DHS pulled 137 kids off, and this year they pulled 500 kids off. But 2 years ago, they pulled 0. So they are serving more youth with developmental disabilities. In the middle column, we advocated for a $10 million cash infusion to the CCBYS program to serve 750 more kids and to develop emergency home-based placements. And over 2,000 kids have been enrolled in the Pathways program, which is run by HFS. And then on the developed capacity, DCFS has distributed over $25 million in capital grant funds to build new residential beds for all the different things in the continuum. But there are 110 beds that have currently been now supported, and there will be 110 more that will come online. So I wanted you to know about that. So I can pause here. I haven't been looking at the chat, so I have no idea. In fact, I can't. Can I? No, there's no questions in the chat. I can pause here before Regina speaks, or Regina can do her turn and we can have Q&A in 10 minutes. But if anyone has a burning question they need answered, I'm not going anywhere, so I can answer now or later. All right, hearing none. Oh, sorry, was there a question?
Nope, that was me.
Okay, go ahead, Regina. I'll keep running slides for you.
All right, thank you, Dr. Weiner. So I want to thank everyone for being here and the opportunity to share with you what we're doing on recommendation number 12 of fortifying our community networks. So as Dr. Weiner mentioned, I took some time to just do a quick scan of what we have available for community networks in the state of Illinois. And once I did that, I also recognized that we needed to have a working, unified definition of what our community networks. And so as you can see, it's an ecosystem of diverse stakeholders coupled with greater supports that can help prevent and mitigate crisis by connecting families. And this is the most important part, with what they say they need to thrive. So we have this as our basic working definition of what a community, what we talk about community networks, what that means. Next slide, please. So in doing the work of gathering information about the various community networks, remembering the heyday of the lands, and thinking about what our future needs are for community networks, I put this little graphic together to just give us an idea of what when we're talking about community networks, what it could potentially look like. So we are looking at a shared vision, coordinated resource, and with a shared vision of coordinated resources at the community level. We are looking at developing what we call network anchors, and that network anchor would be led by committee chair and co-chairs, and they would have the responsibility of coordinating meetings, community outreach, managing projects, and even facilitating training. But the most critical piece to the role of that network anchor would be to ensure that we have the right representation that's a part of the community network. So it's not just focused on providers, which most times when we're talking about community networks, we're thinking that primarily about what the need of providers are. What we want is for this to be holistic in terms of having youth and family voice at the table. So we want parents at the table, we want youth at the table with lived experience, right? We want to have those provider partners. We want to have community members and leaders at the table, as well as those child-serving systems leaders who can make decisions and take information back and forth from the community level to the state level. In the end, what we feel will happen is when we bring all of these pieces together with the network anchor who is leading this work, bringing these community networks together with the right people at the table, we're looking at what our results will be. And we're looking at child-centered, we're looking at reduced home placement disruptions, reduced mental health symptoms, reduced suicide, reduced caregiver burden, and improved school attendance and performance. Next slide. When I went and did an inventory of the networks, this is the list of things that I came up with based upon my experience of working with community networks being located in Central Illinois. I had a pretty good understanding of how community networks should work, right? So I was able to identify some of the lands that are out there that are still working. So I think I came across about 9 of them total. I do some work with the Illinois Children's Healthcare Foundation, so I was familiar with the system of care mental health grantees. So we put them on the list. I'm also very familiar with 708 and 377 boards, so we were able to add them to our inventory, as well as our local health departments, and also those organic networks that are out there, whether it's through a hospital or faith-based organizations or coalitions. We were looking at the gamut of folks that are out there that are saying, hey, coming together as a community to talk about the needs for services and supports is a critical piece of our community, even if we are not necessarily getting funded or are funded to do this work. Next slide, please. As you can see, IDPH is actually our lead state agency working with us on developing this particular recommendation. So what we did was took all of the information about the various networks that we had out there, and we broke them down into the IDPH regions. You can see we have some additional folks that we've listed on here. We have our NAMI affiliates. We have the local area networks. We have those organically formed networks. We have our system of care grantees on here, those 708 and 377 boards, the local health departments in counties with townships. And then we also showed you how those overlapping areas and what that looks like. So as Dr. Weiner stated at the beginning of our presentation, what we discovered is out of 102 counties in the state of Illinois, there is only 1 county that doesn't have a network of some sort that's in their county, which I think we might be able to get around and
change that. Yeah.
Right, we're going to change that. So this is what we discovered, and we were very pleasantly surprised that we have such a great infrastructure within the state at this point. Next slide. So the next steps for strengthening our networks is to prepare materials to illustrate community assets and resources and gaps. So as we begin to develop, work with community networks, we want to give them some tools to put in their hands to do this work of developing their community network. And so from out of our team, we'll develop additional resources so that they can identify what gaps of services or supports are needed within their community. We're looking to continue to work collaboratively with IDPH and HFS on this particular goal. And also, we are looking to support the development of family-run organizations that will be led to partner with the community network anchors, which is a critical piece to the work of what we're going to do to strengthen the stability and sustainability of family-run organizations as well as our community networks. Next slide.
It's back to me, unless you want to talk about this.
No, I'll let you.
Okay. Okay. So as you can hear, we have some key principles, priorities that are driving this work. One is to absorb the complexity behind the scenes. It doesn't matter that the networks are different kinds. It doesn't matter that there's 6 state agencies, because we can, number 2, use technology to make the things that matter to families more accessible and visible to them, and handle all the complexity on the back end. And we're doing that because, number 3, we've heard from families that it's too complicated. And so we're elevating the voices of consumers, engaging parent leadership, even building, and that's a whole other thing we could talk about, building a cohort of parent leaders to make sure there are lots of people who can weigh in on how to make this better for families. And while we're doing that, we're continuing to try to encourage, support, cajole, mandate, interagency collaboration to ensure that this work happens in a way that is more helpful and effective for people. So there's a long list of things that we still have to do. This is a long-term task. But these are some of the things that we're working on now, trying to synchronize there's some financial competition among residential providers. We're trying to make the rates the same across agencies, so there's less of that. Obviously, we're working on Google, delivering services to more people. We met this week about developing a new role out of DHS for personal support workers. We currently have those only for kids with developmental disabilities who qualify for waiver services. We'd like to see those personal support workers available to any family of a young person with a mental health challenge so that we can keep those kids in their family if what is needed is more supervision and support. We will be working with all those community networks that you saw on the previous map to understand what are the gaps in those communities, like what are the service priorities and needs and gaps, so that it comes from the community and not from above. And we'll be working with ISB to develop a readiness assessment based on their landscape scan so that we can start to sequence who's going to go first on universal screening. And of course, standing up the family-run organizations that Regina just talked about. So we've got a lot going on. How can you partner with us? There's a few ways. One, you can collaborate with state agencies to ensure that we're developing geographically and clinically responsive programming. You can work with us and IDPH and all the agencies to reduce stigma around seeking help for mental health challenges. You can work to help provide families, to empower families to help their own kids. We don't want kids coming into the custody of DCFS or DJJ only because they needed psychiatric services. If there's abuse or neglect, that's a different story. But if there's no abuse or neglect and the need is psychiatric services, it is a misconception, a myth that we are debunking, that they will get those services more quickly if DCFS takes custody. That is not the case. And lastly, engage with those community networks. As we raise visibility of these networks, you all should be part of those conversations. So, and we welcome you there. If you want to hear from us, if you're done hearing from us, you can hang up from this webinar and don't worry about it. But if you want to hear more about what we're doing, you can scan this QR code, fill in your information, and you'll be on our list. So when we send updates or invitations we have office hours where we brief the field on what we're doing. We're really trying to be inclusive and use human-centered design. Like there's no point in building this stuff if it's not going to work for people. So help us make it work for people if you're so inclined. And then I think that's all we've got. So I'm actually going to stop sharing. So I know a lot of you have your screens off, but I'm going to stop sharing. So if you want to come on screen, you can, and we can see your face and chat if you have questions for us.
A question, not necessarily a question, but a comment first. So I do chair a children's behavioral health committee. And again, we've looked at some of the pieces of the blueprint where we thought, again, we had some points that we, again, could address. And I think, after your presentation today, first of all, tremendous work, tremendous amount of work in a very short period of time, because these are major systemic issues. Just the fact that you've been able to get all of these agencies together and working together is like major work. But I think probably in looking some of these things we can take back and be more intentional and looking at those. And again, we're looking at that local level. And then when I think about the local level, I'm thinking back to what you're talking about in terms of fortifying those community networks. I know that I've only been in this position with Madison County for 5 years now, but I was in 20 years in St. Clair County and built a great children's network. We had the land and that worked extremely well. Now there was a little bit of seed money, which, as you would know, when there's some money, it doesn't have to be a lot. In fact, we had $30,000 and we never spent all the money, because when we came together as a group and we looked at what was available in the community and we put together a RAP plan, there was a lot of existing things that we could get kids and families involved in and never spent down the money. So I don't know if that's a consideration, but again, providers, when they know there's something to work with that will advance maybe some of the services, that maybe the gaps and need areas that we don't have funding to fund those services, would be very beneficial to have just something to bring that together. Again, for areas that maybe not have that, but that worked beautifully. Everybody was present, involved. We started a youth coalition then, and that was really great. We don't have at the local level, again, we do have NAMI, which is great. And we fund NAMI for children's services in the school and in a number of different areas that we work with them. And we have a couple of family-run organizations. We have a juvenile justice council. But I think for the purpose of children's mental health and what we're looking at here, that I envision something a little bit different than those networks. I think that those all would be a part of it, but one of them on their own wouldn't really satisfy, I think, the looking at these recommendations and the things we would want to move forward. So gave me some really great ideas and thoughts about, maybe some organization at the local level.
That would be great. And Regina, I assume you and Regina are in touch or can be in touch about it so that she hears both your ideas, but also if there are other networks we should be reaching out to, let's make sure we know about them so that they can be part of the process that IDPH and HFS will be helping us with. I'm everywhere I go, I'm like, please help me connect the dots. There's too many dots. So this is a great example of that. Like, just help us connect the dots, make sure we know about the networks you're talking about. And also, if you have strategies that you think we could use, definitely have Regina, make sure Regina knows.
My comment or question, I guess, is similar to what you were just saying, Dana, is that I'm located in the northwest suburbs, technically Cook County, and although our township has we cover 5 municipalities, 2 of which have a NAMI, but for the most part, we sit in between NAMIs. And so we don't have a NAMI that serves the majority of our township. And so on that map, we were covered under NAMI, but the truth is, like, we don't have a NAMI that serves our entire township or the largest municipality of our township. And so I would encourage you, especially those like northern suburban Cook County areas, a lot of times we are sort of in between NAMIs, so to speak, and so we don't get the coverage and we don't get the communication with them like other townships maybe.
I really appreciate that point. And, we were so relieved to see that there was at least one network in every county, because we thought from talking to people and they were like, oh, there's no lands anymore. We thought it was going to be a vast, like, wasteland. We didn't think there was going to be anything. But you're absolutely right that, like, we shouldn't be like, okay, we don't need to worry about that, because there are definitely, having one in a county doesn't mean that everything is covered, especially in more densely populated or large places. So, also, it would be good to know, like, a separate conversation maybe, but when you say covered by NAMI, like, what NAMI is doing. Like, I heard some school-based services, and I know they do the stigma reduction in schools, which is wonderful, and we're partnering with them too. But if there are things that we should know about that you're referring to, because I suspect it's not just network and public awareness. Is some of it direct service?
Well, here we don't have any direct service
Right.
from NAMI.
Understood.
We have a support group that occasionally meets, but I know, in other municipalities and other counties, NAMI is a lot more active. And I know, Cook County is weird because it is so densely populated. So there's areas of Cook County where NAMI is doing a lot of school-based work. But here out in the northwest suburbs, we don't experience that.
Yeah, we have all of the training, different programs that they do, basics, family to family, and again, we are, the mental health board funds them to go into one of our schools that really has the most issues in relationship to school issues are paramount with youth in that school. And so they're doing support services within the school, which is great. I guess my question is, have you guys had a conversation with NAMI in terms of maybe being the hub of this, bringing others together in the community to do this work? Because I know they're volunteer based. And so to what extent are they capable of managing or coordinating within the community? Because I think it's a beautiful place to be, Regina, because you have the youth, we have youth represented, we have parents represented there, and we want their voice involved in this, as well as they're working with local providers and schools and that kind of thing. So I think they would be a really great entity to work with. But do they have the capacity, I guess, is the question, to manage and coordinate things with other service agencies and that type of thing within the community?
Yeah, so I will just say, I don't think we have all the details of our collaboration with them fleshed out, but Andy Wade is definitely a partner in this work, and we've had multiple conversations with him. We have a little bit of a more specific sense of how we're going to partner with NAMI Chicago, because they have a robust helpline, and we're going to be leveraging their helpline for navigational assistance in the local Cook County cases. But in terms of NAMI Illinois, we know we want to work with their stigma reduction and public awareness stuff, but we haven't yet fleshed out all the details of how that partnership is going to look, but we definitely consider them partners. I mean, there are many, many groups, like the Illinois chapter of the American Academy of Pediatrics is another one. Like I meet with Jenny Pinkwater regularly, Illinois Hospital Association. Like there are so many groups. Fortunately, I'm an extrovert, so I like talking to people, but there are so many groups of people to like make sure they know what we're doing and that we're using the stuff that they're doing. Because I don't want to reinvent the wheel. I'm a big believer in figuring out what we have that's working and then building it up and shining a light on it. I don't want to dismantle something in favor of some other thing, because we've got plenty of stuff that's good. We just need to make people aware of it and make sure they can get to it easily.
Yeah, one of
Yeah.
our, go
I
ahead.
see Sam too. No, go ahead. Go ahead, Deborah. What were you gonna
I was
say?
just going to say, one of our mandates is a 1 and 3 year plan for community mental health authorities. And mine is one of my big 5 goals is children's behavioral health. And I have a system development fund that's just for focus of something like this. So again, we contract with NAMI. That would be a really great place again for us to utilize our funding to support something of that nature. So something, again, the local community might not, and that I speak for myself, all mental health boards are not created equal. We have different funding and different possibilities to do different things. So
can I go ahead? Sorry.
Mhm.
Yeah, okay. So we have a 553, a Board of Health, that provides funding to an agency that then has staff that does the NAMI Ending the Silence program. And so then that youth suicide prevention program that, so it's in McLean County. And so then they provide that to, I think, a grade school level and then a middle school level, or maybe it's a middle school and high school. I can't remember. So in our experience, like for our local NAMI chapter, they don't have like the paid staff, or they don't have like the capacity to take that on. And so that's one of the ways that we have done that is NAMI has some evidence-based programming. And so then again, just staffing an agency that does that. However, I will say that I would be interested if like one of the ACMI members boards is able to directly fund NAMI, because one of the challenges with us funding the agency is the program doesn't grow. It only has 2 staff members. And so it doesn't grow as much as if like NAMI was doing it, it would be like a higher priority, because we really need this program to grow, and the agency does not want it to grow. Even if we provided them with the funding, they don't want it to grow. So.
Interesting. Yeah, I mean, we're also trying to think creatively about how to leverage some of the philanthropic partners who really want to support this work, but sometimes that kind of funding it can't be for like an ongoing operational function. It can be for like a planning function or a, initial stand-up. So thinking about how we leverage those funds while we work within state government to find money that we can use for the ongoing each agency does that through a slightly different mechanism. So you're absolutely right that it is not an easy thing to get this stuff up and sustainable. Regina, do you have thoughts in response to these questions or points? Am I missing anything?
We have any?
No, I'm sorry. Get off of mute. No, I'm okay. You're covering it well. Thank you.
And I just want to say, so I'm in DeKalb County, and Regina came and talked to my 708 board a few years ago, and we're not much further than we were then, Regina, but this is something that's been on our plate for a long time. So we do a ton of community networking, getting everybody together, talking about what's going on. And where we're at is it's just also, like you have found, it's all over the place. Like, and nobody's talking, nobody's communicating. we have programs here that accept one kind of payment over there. And so I'm so grateful for the communication opportunity that you're going to give to make sure that we're one, not duplicating something that's going to come from what you're doing already, and then how we can be supportive. And we were in our area, we also have NAMI on the map, but our ROE is super involved. They run our IRIS program. They're really invested in birth to 8 mental health, and that's an area that we're supporting as well. But it just feels like we are all over the place and trying to really streamline what those needs are and then how to get that met. I think that I signed up right away as soon as I saw your QR code, because I think just having that communication and information is going to be so valuable. So thank you for your time today and for providing that.
Sure. I mean, it's a big, entrenched, complicated problem. And when I first took this on, I was a little scared, but then I was like, well, I'm not going to make it worse. And if I can make it a little bit better, that would be a good thing. And I think in some ways we're making it considerably better by, and we're building things that are not going to be dismantled anytime soon, both processes and fiscal adjustments, things you can see and things you can't see that I think are going to make things better overall. But it's a hard problem to solve because it's so complicated. But I'm glad you're going to keep in touch with us. Anything else?
And if it's okay, would we be able to have a copy of the slideshow? I'd love to send that out with the QR code and the link to the report that you pasted into
that's
the.
fine. There's some other materials that I would even share. We can send you the slide deck, Regina can or I can, but there are also some materials that have been developed that capture some of what we've learned about resources that the state funds that people may or may not be aware of that are available to people. So for example, we just learned 2 days ago about a gambling addiction program that Super administers. And we learned about the first episode psychosis program that's all over the state. 30 providers deliver it. And to qualify, you have to be experiencing psychotic symptoms and you haven't had them for more than 18 months, but you can be any 14 years old and up. So we've learned about all these programs. So we have some documents that we've just distributed through with DCFS's help to make sure people are aware of those. So happy to share that flyer with you too.
That would be great. I appreciate that.
Okay, cool.
One of the things, Dana, we created it with our Children's Behavioral Health Committee was evidence-based. We actually sent out surveys across our membership and tried to get to as many communities as we can. I can't remember, Jody can share probably how many agencies we actually, or how many we actually had entered in, but it was a start. We were hoping that once we had the information up there where you can actually do searches and find out what evidence-based practices are there, where they're being conducted, and what types of things are involved in those various evidence-based practices. But we were hoping to grow it by really marketing that out there so people could see what exists in Illinois, but just kind of an FYI that's there. And hopefully we probably need to do something again to market it. It's on our website, but we probably need to do more marketing to get more.
Will you put the link to it in the chat?
Yeah, I'm actually trying to do that right now. My computer was slow, so hold just a sec.
Again, Deanna, her, your IT department, that's not right, but they helped us develop that.
Yeah, our IMO department's really big on the mapping piece. And so they were super excited to be involved with that.
Yeah, and we're still collecting information. It's sort of a living document for any best practices. So there's a link on there. Obviously, we're missing a lot of services and locations throughout the state. So if you know of anything, or if you have any networks you want to forward that on to.
Well, I'll post, I think you guys know about Spider, right?
Yes.
Okay, right. So I just sent what you just showed me, what the link you just put in the chat. I sent it to the team that's working on the Google portal so that they know that this is out there. We might follow up with questions. But this is what I mean, connecting the dots. Like, it's so hard, but it's great if we can do it. We can get everything, you know, at least tracked in one place.
Awesome. Well, this has been wonderful and very informative. We appreciate everybody being here, especially Dr. Weiner and Regina for both for your time and effort and all of the information that you shared. And we will follow up with the archived recording and all of the materials that was discussed today, so folks can share it with their networks and their, you know, fellow board members and everything. So thank you so much. Appreciate it.
Good to
Thank
see you.
you.
Have a great day.
Good to
Thank
see you
you.
again, Deanna. All right.